for current Omicron settings. आपण एक 5 मिनिटात सुरू करू. In this today's talk, first I will discuss how Omicron is different from COVID, Delta variant of COVID virus and other variants, why it is more infective, why it is escaping vaccine, why it is escaping patients with previous infection. And then we'll move on how the management is different from previous Delta variant. And what test we should do, what tests you should avoid initially, and when to do, and how to manage this. All the part related to vaccine and drugs for management of COVID, along with how it is different from Omicron, will be discussed by Dr. Swapnil Sakhla. And after following both talks, we will have question answer session. So for question answer, you can put your questions in the chat box so that questions will be answered after both the talks are over. Okay, so let's start with the session. So we'll discuss this talk under following headings. So what is Omicron, how it is different from Delta and other previous variants, how is its pathogenesis and virulence is different, how it is affecting bronchial wall, how it is affecting lungs, how to evaluate patient clinically, testing and timing tests which are to be done, timing and need. And that includes rapid antigen tests, RT-PCR, genome sequencing, antibody testing, various blood tests that we were initially doing since start of COVID, and timing for HRCT. In Delta, HRCT was done outright. On day one, we were doing HRCTs. So how, what is the utility of HRCT in current settings? And in treatment options will be discussed by Dr. Swapnil, in which all new elements, including molnupiravir, status of cocktail antibody, remdesivir, where remdesivir stands in current Omicron settings, and vaccinations, various vaccines, their escape, need for booster, all these points will be discussed by Dr. Swapnil. So let's start. So this is the picture of COVID-19 virus, and these are the spike proteins. With the help of these spike proteins, virus attaches to the host cell, and there are the more than 30 mutations have occurred in Omicron in these spike proteins, because and whenever any neutralizing antibody is also acting, it is attaching to the spike protein so that spike protein doesn't get attached to the cells. And because there is change in amino acid sequence in due to mutation here, these various neutralizing antibodies, whether it are vaccine induced, whether previous infection induced, or monoclonal antibodies that we are using till now for Delta, are not able to neutralize this virus. So we'll see all these points in detail in next few sets. So mutations are changes to amino acids within the genome. If mutation changes the virus enough, it becomes a new variant. So first change from original COVID-19 virus was G614G, and that is an early mutation to the original strain. And this variation is present in all, this D614G mutation is present in all viruses, be it alpha, delta, or now in Omicron. So Omicron carries about 50 mutations not seen in combinations before, including more than 30 mutations on spike proteins that coronavirus uses to attach immunocells. So more than 30 variations have occurred, and because of that, its attachment is different, and that's why it is become more transmissible. So if you compare, so every spike on coronavirus surface is made up of 3 identical proteins twisted together, making it look like a little head of broccoli with 3 stalks. So each stalk has 3 vital regions. One is RBD, that is receptor binding domain. Another is N-terminal domain, and the furin cleavage site. If you see this picture, microscopic picture, this is the receptor binding domain, this is NTD, and this is the fusion cleavage site. And maximum mutations in Omicron has occurred at receptor binding site. And because they have attached at receptor binding site, that's why it has become more transmissible. If you see with different variants, this is NTD, this is RBD, and this is fusion cleavage sites. And if you see, these are the mutations we can see here. So maximum mutations in Omicron have occurred at receptor binding sites. Okay. And because of these variations, it has become more transmissible. See, first variant which was we isolated was beta, then alpha, then delta, which was isolated in India, gamma, and now Omicron. We can see it started with 11, 10, 9, 12. Now Omicron has got more than 36 variations. So Omicron is more infectious than other variants. Several of mutations on Omicron are associated with increased transmissibility. So it is 3 to 5 times more infectious than Delta. Now, there are various theories how these mutations have occurred. There is one theory that this virus may be present in an immunocompromised host. म्हणजे एखादा पेशंट HIV इन्फेक्टेड असेल किंवा एखादा इम्युनोकॉम्प्रोमाइज ट्रान्सप्लांट रिसिपिएंट असेल and he is not able to clear the virus from the body. And they are saying that more than almost a year that virus has stayed in his body, and because of that, that virus has mutated, and because of that mutations, the new variant has occurred. Now, thing is that these mutations will keep on occurring unless more and more people get vaccinated. Unvaccinated people will harbor this virus, and they will mutate the virus, and that will spread. Virus जितका replicate होईल, जितका spread होईल, तितका तो mutate होत राहील. So for stopping this pandemic, that virus spread needs to be stopped. But this will happen when all the people will get vaccinated, and then the mutations will stop. So that is the thing that we want to get. Now, problem is that, as I have told you, that spike proteins, all antibodies get attached to spike proteins and prevent that spike protein from attaching to the host cell. So because there are many variations that are occurred in this Omicron variant, the antibodies are failed to neutralize it. So these antibodies developed to attack spikes of previous version of virus, which were largely similar to each other. Upon both like alpha, delta, gamma, all had almost similar features. So they were all active against these things. But antibodies find it more difficult to attach the vastly different Omicron spike. And that's why we are getting infection in this. In antibodies, monoclonal antibodies, the routine that is available in India is not active. It should not be used now unless we prove that it is a Delta variant. Only antibody that can be used is Sotrovimab, produced by GSK, and that is not available in India. So for monoclonal antibodies, till last week we used monoclonal antibody. But now, if you want to use monoclonal antibody, you have to prove that it is not Omicron, it is Delta. And proving it is a difficult task. We will see in the further slides how to diagnose it and how to prevent. Now, almost 80 to 90% infections that we are getting in India are now Omicron. So unless proven otherwise, we have to take that all patients of COVID that we are getting are Omicron in India now. So this is the data, recent data from UK, confirm Omicron's vaccine escape. Swapnil will discuss in detail, but I will just share this one slide. They have studied with 2 doses of Pfizer and 2 doses of AstraZeneca, that is Covishield in India, same vaccine, that is Covishield. So with 2 doses of Pfizer, those who have taken, they are only 20% effective in preventing symptomatic Omicron. The patient of Omicron's infection, he will produce symptoms. Is only 20% effective 2 doses of Pfizer. 2 doses of AstraZeneca or Covishield is 0% effective in preventing symptomatic Omicron. म्हणजे त्यांनी कोविशिल्डचे 2 डोस घेतलेत तर त्यांना Omicron पासून प्रोटेक्शन मिळणं, symptomatic Omicron पासून प्रोटेक्शन मिळणं is only 0%. But those who have taken booster of Pfizer, 80% effective in preventing symptomatic Omicron. And those who have taken booster of Covishield, it is 55% effective in preventing symptomatic Omicron. So this emphasizes need for booster dose. Now you have to remember that though all the studies we will see in future, though all vaccines have failed in preventing symptomatic Omicron, but all vaccines have protected people from getting severe COVID disease, for need for hospitalization, need for oxygen, need for ventilation, death, all in which all these vaccines have helped. So even we are getting infection now, we are seeing all Omicron, all healthcare workers, we are getting rapid positivity in healthcare workers also, but the symptoms are mild. So all vaccinated people have, or previous infection people have got disadvantage. This was in US. One study was that they have studied one ICU. These are patients who are admitted in hospital but not in ICU. So in unvaccinated cases, you can see these are the patients who are admitted in hospital but they are not in ICU. So we can see there are almost 900 patients, of which 236 are unvaccinated, 536 are fully vaccinated, and 42 are partially or with single dose. But you can see here the majority of patients are vaccinated. But if you see, come to ICU, almost 80%, 70% of the patients in ICU are unvaccinated. So you can see that vaccines are preventing you going into ICU or getting serious disease. Past infection, Omicron doesn't protect against past infection with any COVID. Suppose we had Delta, it will not protect against Omicron, because previously when we got infected with COVID, reinfection rate was very less. It was giving almost 80% protection from reinfection risk. But protection from reinfection by Omicron afforded by past infection is as low as 19%. 19% is nothing. So get protection. So risk of infection to Omicron variant is 5.4 times greater than that of Delta variant. That's why we are getting previously infected patients, vaccinated patients who are getting vaccine, and healthcare workers are getting COVID. So that is the picture. See, we can see he's calling nurse and nurse is admitted on the side bed. So she's saying yes. So that is the scene. So healthcare worker protection is also very important. Even in our hospital setting, all healthcare workers who are getting first symptom needs to be isolated fast, because they will infect other people in our hospital setting, healthcare workers, and then our force who is required to work for COVID treatment will, or other non-COVID facilities will be very less. So how this Omicron has affected India? Till last week of December, we had only around 10,000 or less than 10,000 cases. And the cases from, I think, 28th of December, they started jumping. This is 2 days back, yesterday's figure. India have got 2,41,900 patients positive. If you see in a day, and if you see UK, France, which has got population very less, Italy, they are stroking 2 lakh, 3 lakh cases. US is almost 7 lakh, 8 lakh, even it has crossed 10 lakh also. So this is the number, which sheer number which people are increasing. If you see weekly trends, in India, cases last week, in last 7 days were 10 lakh, and cases in that preceding 7 days were 2 lakh. So increase jump is 400%. So if you say for 10 lakh, in next week we will 400% change, then the cases will go to 30-40 lakhs in a week. So that sheer number, because we can say Omicron is a mild variant, but it is definitely going to affect people with comorbidities. It's definitely going to immunocompromised patients, and sheer number is very high. So in short case, the number will burden our healthcare system. So these are the daily new cases. This is from the start of the pandemic. We can see first wave, second wave. Now this is the third wave, which is picking up. In second wave in Delta variant, we reached around 4,20,000 cases. Now here we may reach around 10 lakh cases per day in next few days. So these are the active cases. Now look at this number, which is very interesting. This is the daily deaths in India. This was around first peak of P wave. It can match the peak of P wave and peak of cases and death. Same as Delta. In Delta, we almost reached 5,000 deaths per day. Now, even now, cases have reached around 2.5 lakhs, but deaths are remaining around 200 or less. This number will definitely increase in next few days, but this indicates that virus is less virulent as compared to previous strains. So ICMR has revised testing guidelines on 10th of January. Why this testing guidelines revision was necessary? Because now all the tests that are increasing rapidly, that will put pressure on the RT-PCR kits, and we will get shortage of kits, because all over the world the kits will be used and the cases will be short. So who may be tested in community setting? All patients who have got symptoms, cough, fever, sore throat, breathlessness, or the respiratory symptoms should be tested, and they should be isolated. Now look at the second point. Second point is, previously it was instruction that all contacts of the positive patient should need this to be tested. Now they have modified this guideline. They have said that only at-risk contacts of laboratory confirmed cases should be tested. At risk means which has got elderly, more than 60-year-old, individuals with comorbidities like diabetes, hypertension, chronic lung disease, or malignancy or obesity, etc. So if you have got a patient who is positive in other contexts has no symptoms, so they need not be tested if they are not at risk. Then individuals undertaking international travel and international travelers who are arriving in India as per laid down by guidelines. Now, who may be tested in hospital setting. This is very important. This is also slight variation from which we were doing earlier. So they are saying that no emergency procedure, including surgery, should be delayed for lack of a test. Patients should not be referred to other facilities for lack of testing facility in your hospital. So you should arrange testing facility at your hospital. All asymptomatic patients undergoing surgical or non-surgical invasive procedures, including pregnant women in labor, who are hospitalized for delivery, should not be tested unless warranted or symptoms develop. Upon याच्या सगळ्या patient, those who are getting hospitalized and are going for surgery, we're testing them. Now they are telling that all asymptomatic patients need not be tested. And once suppose you have got admitted a patient and you need to do a procedure after a week, so you do not retest it. Okay, admitted patient can be retested if they develop symptoms. Okay. Now, people who need not be tested, asymptomatic individuals in community setting, contacts of confirmed cases if they are not high risk. This is very important. Third point, patients who stand discharged as per home isolation guidelines. आता आपल्याकडे गव्हर्नमेंट मिनिस्ट्री ऑफ हेल्थ अँड फॅमिली वेलफेअर गिव्हन 7 days होम क्वारंटाईन गाईडलाईन्स. प्रत्येक पेशंट आपल्याला प्रश्न विचारेल की डॉक्टर मी 7व्या दिवशी टेस्ट रिपीट करू का? तो दे नीड नॉट बी टेस्टेड बिकॉज टेस्ट कॅन रिमेन पॉझिटिव्ह फॉर वीक्स आफ्टर यू गेट इन्फेक्शन. For patients who are being discharged from your hospital as per revised discharge policy, they are not to be tested for COVID negative. And another important point, fifth, individuals undertaking interstate domestic travel. आता आपण प्रत्येकाने who have previously traveled in last 1 or 2 months, if you want to travel to different state, you have to take RT-PCR and show RT-PCR report on arrival on airport or railway station. But now interstate domestic travel, they have stopped. People should not be tested. So algorithm for COVID-19 testing. आता टेस्ट मध्ये आपण काय काय करू शकतो? So there are few slides about rapid antigen test. The rapid antigen test has a big utility if you see now, because as the tests are increasing, so burden on RT-PCR kits will increase. Previously in Nasik we got so many RT-PCR labs, we were getting reports in 4 to 5 hours for RT-PCR. Now these people are now taking almost 24 hours or more than 24 hours now. If the test will increase, then the reporting time will still more increase. So if you got a symptomatic patient, in that case, rapid antigen test is very useful. If rapid antigen test is positive, it is to be reported as positive. And then you need not repeat a test, because you remember rapid antigen test positivity, it has got very good specificity. Only thing is its sensitivity is very low. It is sensitivity is almost 50 to 60% only. If rapid antigen test is negative and patient is symptomatic, fever, cough, sore throat, then you should proceed for retesting by RT-PCR. And if you have got symptom, and even if your rapid antigen test is negative, you should ask your patient to isolate himself. Okay, that is a very important thing. So as testing increases, we will get pressure on RT-PCR kits, which will delay testing results. So RT kits are cheap, easily available. Patient can self-test and give result in 10 minutes. When you are taking sample for a rapid antigen test, there are 2 ways. You should take nasopharyngeal swabs, both one from nose and one from throat. All the technicians that are doing RT, that they're taking only swab from nasal. If you want to increase the yield of the test, you should take both nose and pharynx swab. There is high false negative rates, especially for Omicron in rapid antigen test, so it is 40 to 60% negative. False negative म्हणजे काय की पेशंट पॉझिटिव्ह असेल, त्याला इन्फेक्शन आहे आणि टेस्टने ते निगेटिव्ह रिपोर्ट देणे. So false negative rates are high for Omicron, almost 40 to 60%. So if anyone has symptoms, he must isolate even if RT is negative, and then he should proceed for RT-PCR. So antigen tests, they are used for diagnosis of current infection. Nasopharyngeal or nasal swabs are used. Antigen tests are generally less sensitive than nucleic acid or RT-PCR tests. Sensitivity, but their sensitivity is highest in individuals within 5 to 7 days of symptom onset. म्हणजे पेशंटला लक्षण सुरू झालेलं इमिडिएटली जर आपण टेस्टिंग केलं तर RT-PCR रॅपिड अँटिजन टेस्ट पॉझिटिव्ह चान्सेस जास्त आहेत. सो टाइम टू परफॉर्म टेस्ट इज लेस देन 1 hour. नाउ कमिंग टू RT-PCR जे आपण आता सगळे करतोय. Now in RT-PCR they are testing 4 genes, N, S, C and ORF. Only few labs in are checking for all these 4 genes. मेनली ओमायक्रॉनचं जर इनडायरेक्ट आपल्याला आरटीपीसीआर जर इव्हेंट पाहिजे असेल तर एसजीन टार्गेट फेल्युअर इज इनडायरेक्ट एव्हिडन्स ऑफ ओमायक्रॉन. म्हणजे एसजीनचं टार्गेट फेल्युअर जर असेल तर आपण म्हणू शकतो की हा ओमायक्रॉन असण्याची शक्यता दाट आहे. पण आपल्याकडे इंडियामध्ये टेस्ट करणाऱ्या कुठल्याही किटमध्ये अजूनही ते होत नाही. नाउ टाटा हॅज डेव्हलप वन किट विच विल कम टू मार्केट सून विच विल डिटेक्ट दिस एसजीन टार्गेट फेल्युअर. So this is about RT-PCR. RT-PCR is used about diagnosis of current infection. स्पेसिमेन इज रेस्पिरेटरी ट्रॅक स्पेसिमेन्स म्हटलं. त्याच्यामध्ये आरटीपीसीआर मध्ये आपण काय काय वापरू शकतो? एक तर नेझोफेरेंजियल स्वॅब्स वापरू शकतो. वी कॅन यूज ब्रॉन्को अल्व्हेलर लवाज काही काही केसेसमध्ये, दॅट इज द रेस्पिरेटरी स्पेसिमेन. इट हॅज गॉट हाय सेन्सिटिव्हिटी अँड स्पेसिफिसिटी इन आयडियल सेटिंग्स. क्लिनिकल परफॉर्मन्स डिपेंड्स ऑन टाइप अँड क्वालिटी ऑफ द स्पेसिमेन अँड ड्युरेशन ऑफ इलनेस ऍट द टाइम ऑफ टेस्टिंग. फॉल्स निगेटिव्ह जेव्हा येतात ना, तेव्हा एक तर स्पेसिमेन कलेक्शनची क्वालिटी पुअर असेल, किंवा एखादा पेशंट खूप उशिरा इलनेस मध्ये असेल, सेकंड किंवा थर्ड वीक मध्ये असेल. पेशंटचं जसं इलनेसचं ड्युरेशन वाढतो तसं मग टेस्ट निगेटिव्हचे चान्सेस वाढतात. ओके, सो फॉल्स निगेटिव्हिटी फॉर दिस इज 5 to 40%. टाइम टू परफॉर्म टेस्ट रेंजेस फ्रॉम 15 minutes to 8 hours. टर्नअराउंड टाइम इज इन्फ्लुएन्स्ड बाय द टेस्ट यूज अँड लॅबोरेटरी वर्कफ्लो. वर्कफ्लो वाढला की टेस्टचा टर्नअराउंड टाइम विल इन्क्रीज. नाउ दिस इज व्हेरी इम्पॉर्टंट टॉपिक दॅट आय नीड टू हायलाइट. आता प्रत्येक पेशंट आपल्याकडे येतो आणि ते सिटी व्हॅल्यू दाखवतो टेस्टच्या. सर माझी सिटी व्हॅल्यू 19 आहे, 22 आहे, आता काय करायचं? सो व्हॉट इज दिस सिटी व्हॅल्यूज? द सायकल थ्रेशोल्ड रिफर्स टू द नंबर ऑफ सायकल्स इन एन आरटीपीसीआर assay that needed to amplify viral RNA to reach a detectable level. Generally, these people test for 35 cycles. Initially 40 करत होते, and if in 35 cycles virus is not detected, they used to label it as negative. म्हणजे त्याचा अर्थ की सिटी व्हॅल्यू कॅन दस इंडिकेट द रिलेटिव्ह व्हायरल आरएनए लेवल इन अ स्पेसिमेन. त्या स्पेसिमेन मध्ये व्हायरल आरएनएची लेवल जर जास्त असेल, तो कदाचित सुरुवातीला 10व्या 15व्या सायकललाच पॉझिटिव्ह, म्हणजे 15व्या सायकलला पॉझिटिव्ह म्हणजे व्हायरल आरएनए लोड जास्त, असा इनडायरेक्ट आपण इन्फरन्स काढू शकतो. पण दिस क्लिनिकल ऍप्लिकेशन ऑफ दिस सिटी व्हॅल्यू इज रिअली अनसर्टन. एक तर पहिले सिटी व्हॅल्यूज आर नॉट स्टँडर्डाइज अक्रॉस डिफरंट आरटीपीसीआर प्लॅटफॉर्म्स, सो रिझल्ट कॅनॉट बी कम्पेअर्ड अक्रॉस डिफरंट टेस्ट. आणि स्टडीज अशा प्रूव्ह नाही केल्या की सिटी व्हॅल्यू 11 आहे आणि तो पेशंटने खूप पुअर परफॉर्म केलं, किंवा सिटी व्हॅल्यू 30 आहे and that patient has performed well. So these studies have not concluded to the evidence that CT value low means patient has got severe illness. So any patient coming to you with is telling that my CT value is high. So in that case, CT value is very low, and whether it is serious infection, you can tell it is not like that. You have to assess patient clinically, what are his symptoms and how he is progressing, and then only you can make a clinical judgment. So don't rely on CT value for severity of the illness. Few slides about this antibody detection. जी आपण सार्स अँटीबॉडी जी आयजीजी डिटेक्ट करतो, हॅज गॉट नो युटिलिटी फॉर डायग्नोसिस इन अॅक्यूट आउट पेशंट सेटिंग. म्हणजे अॅक्यूट इलनेस मध्ये अँटीबॉडी डिटेक्शनला काही व्हॅल्यू नाहीये. सो वी डू नॉट यूज सिरोलॉजी टू एक्सक्लूड डायग्नोसिस ऑफ अॅक्यूट कोविड-19 इन्फेक्शन. पण सिरोलॉजी आपण कधी वापरू शकतो? एखादा पेशंट इज इन द 3rd week ऑफ इलनेस, आधीचे आरटीपीसीआर त्याचे निगेटिव्ह आले, and we are suspecting, we have got one patient now, young female, we are not unable to diagnose in which direction she is going. She has got now respiratory lung मध्ये fibrosis दाखवतो. Now we have tested her antibody titer is very high. So in that case we can say that she had infection which was not been detected on previous RT-PCR test, and now her antibody titer is high. So we can retrospectively in that case we can say, so this is not an acute setting, it is subacute or chronic setting मध्ये आपण तिला वापरू शकतो. So serology or antibody detection, diagnosis of prior infection, at least 3 to 4 weeks duration. Sample is blood. So sensitivity and specificity are very variable. Detectable antibody generally takes several days or weeks to develop. जनरली 14 दिवस लागतात अँटीबॉडी डेव्हलप व्हायला, म्हणून आपण वॅक्सिनेशन नंतर 14 दिवस असं म्हणतो की त्याला प्रोटेक्शन मिळालं. क्रॉस रिएक्टिव्हिटी विथ अदर कोरोना व्हायरस rather than SARS-CoV-2 has been reported. Time to perform ranges from 15 minutes to 2 hours. Turnaround time is influenced by laboratory and workflow. It remains uncertain whether positive antibodies indicates immunity against future infection. हा पण खूप महत्वाचा पॉईंट आहे की तुमचा अँटीबॉडी टायटर हाय आहे. काही लोक ते अँटीबॉडी टायटर हाय अँड दे आर रिलॅक्स की आम्ही आता आमचा अँटीबॉडी टायटर खूप हाय आहे आणि आम्ही आता काही घाबरण्याची गरज नाही. सो इट इज नॉट लाईक दॅट. वी डोंट नो. आणि ओमायक्रॉनच्या केसमध्ये तर अँटीबॉडी टायटर आपल्याला कळणारच नाही की आपल्याला ओमायक्रॉन पासून प्रिव्हेन्शन होईल का नाही. त्यामुळे अँटीबॉडी टायटर्सने हे कोरिलेट करणं डिफिकल्ट होईल. फ्यू लाईन्स अबाउट जिनोमिक टेस्टिंग. जिनोमिक टेस्टिंग जी आपण वापरली जाते ती ओमायक्रॉन व्हेरियंट डायग्नोस म्हणजे जे पण म्युटेशन आपण आता पाहिले ते डायग्नोस करण्यासाठी जिनोमिक टेस्टिंग वापरली जाते. बट नाव गव्हर्नमेंट हॅज क्लिअरली ॲडवाइज दॅट वी शुड नॉट ऑर्डर जिनोमिक टेस्ट, त्याच्याने अननेसेसरी लॅब्स ऑफ प्रेशर येईल. सो जिनोमिक टेस्टिंग इज नाव युज्ड फॉर रिसर्च पर्पज अँड अनदर फॉर गव्हर्नमेंट टू टूल अँड टेस्ट track the epidemic. So it is for research and it is for government tool. So genomic testing is not advised by us. So it will be advised by government or it is used for research purpose. Now very important point about blood test and HRCT. आता आपल्याकडे पेशंट आला प्रिव्हियसली डेल्टा वेव्ह मध्ये. सो वी यूज टू डू CBC, CRP, D dimer, and then LDH and other assays. So what are the, is there a need to do blood test at initial? In this case, I will show in future further slide. If patient has got mild symptoms, he doesn't have any comorbidity, we did not do anything. कुठलीच टेस्ट करण्याची गरज नाही. Not blood test, not HRCT. Blood test and HRCT. HRCT, if you want to do, you will do if patient has got low respiratory symptoms, he has got cough with expectoration, he has got saturation which is dropping below 92%. In that case, you should do HRCT. Otherwise, there is no need to do HRCT. आता पण तुम्ही बघितलं असेल आपण HRCT केलं तर ऑलमोस्ट सगळ्यांचे स्कोर 0 येतात. ते पण काय होतंय ते पण आपण पुढच्या काही स्लाइड मध्ये बघू. So this Omicron is presenting as common cold or flu. Atta at this juncture in India, if any patient is coming to with respiratory symptoms, who has got fever, but he has to have fever and he has got body ache. Body ache is very important. Backache we are getting in many patients, backache which is very important. So we, unless proven otherwise, you have to treat it as he has got Omicron. Incubation period is very short. Previously, Delta madhe COVID incubation period was around 5 to 14 days. Here incubation period is very short. 3 दिवसात exposure झाल्यावर 3 दिवसात patient will start developing symptom. If anyone gets flu-like symptoms, assume that you have got COVID unless proven otherwise. And important is isolate unless you get the test results. Another important positive point about this is there are symptom duration is very short. Now, आपण पेशंट बघतोय ओपीडी बेसिसवर. एक तर हार्डली मेनी पेशंट्स आर रिक्वायरिंग सेकंड फॉलोअप आणि सेकंड पेशंटला आपण काही सिम्पटॅटिकली ट्रीट केलं, पॅरासिटामॉल अँटीहिस्टॅमिक दिलं. मोस्ट ऑफ देम आर गेटिंग बेटर इन नेक्स्ट 2 or 3 days. So because of that, the isolation policy guidelines have changed. American CDC has said that isolation period for Omicron is just 5 days. France is 7 days. In India, Ministry of Health and Family Welfare 2 days back they have issued a guideline that patient under home isolation will stand discharge and end isolation after 7 days pass from testing positive. त्याच्यात त्यांनी एक कंडिशन ऍड केली की he should have no fever for last 3 days before he ends his isolation and he should continue to wear mask whenever he goes out. There is no need for retesting after home isolation period is over. That we have seen in previous slide also. Asymptomatic contacts of infected individuals need not undergo COVID test. They just monitor health in home quarantine. So what is the gray lining in this Omicron? We know that Omicron is going to spread rapidly. We are going to get rapid increase in cases. Nashik madhe, we feel that next 1 or 2 weeks we can get a peak. Cases will rise sharply. So Omicron cases are less severe than Delta, but number of infection may still overlap hospital. कारण number of infection खूप जास्त होतील, त्यामुळे सिरियस जरी पर्सेंटेज कमी असलं तरी ते पर्सेंटेज विल overwhelm the hospital system. It will affect younger patients. I will show you. आज म्हणजे काल रात्रीतनं 7 वाजेपासून I have received a call from around 4 to 5 patients. त्यांचे मुलं 12, 14, 15 वर्षाचे आहेत की हाय ग्रेड fever is not getting. I got admitted one 15-year patient yesterday, 15 वर्षाचा मुलगा. So it is going to affect younger patients. It is going to affect females more than males. But need for hospitalization will be less. Oxygen requirement will be less, and ICU requirement will be less. Now, we at Rane, me and Swapnil, were treating. We had COVID since we started hospital. We got COVID ward. In last almost 7 to 8 months, we had patients and who were requiring oxygen, mechanical ventilation. As this Omicron wave started, we are getting less and less number of patients who are requiring BiPAP, mechanical ventilation, or requiring oxygen where they are requiring, but that oxygen requirement is getting reduced very fast as compared to previous patients. So that is this. So why this is happening? It is because virus is milder and population is either protected due to immunity due to vaccine or previous infection. So Omicron has got very high infectivity. The bronchial cells ला अटॅच होण्याची त्याची पॉवर खूप जास्त आहे, त्यामुळे त्याची स्प्रेड इज व्हेरी फास्ट. बट लंग आणि लंग सेल्सला अटॅच होऊन इन्फेक्शन करण्याची पर्सेंटेज आहे as compared to past variant is very low. So it is very less likely to therefore cause pneumonia as compared to other variants. So chances of pneumonia with Omicron are less as compared to Delta variant. त्यामुळे फक्त नंबरच इतका राहील ओमायक्रॉनचा की वी विल गेट इफ pneumonia is less but number of people infected will be very high. त्यामुळे patients of pneumonia that will get will be more. So this is UK data on Omicron severity. त्यांच्याकडे इमर्जन्सी मध्ये प्रेझेंट होण्याचं प्रमाण इज लेस 45% ऍज कम्पेअर टू प्रिव्हियस इयर. 70 समजा एखादा पेशंट आपल्याकडे इमर्जन्सी मध्ये आला तरी त्याला ऍडमिशन लागण्याचे चान्सेस आर 70% लेस. And all people who are admitted has shorter hospitalization stay, maybe 3 to 5 days max. This is very interesting article presented in JAMA just on December 30th. Now South Africa and Botswana were the first two countries which diagnosed this Omicron variant. त्यामुळे साऊथ आफ्रिकेमध्ये ओमायक्रॉनची वेव पहिली आली. So now this is very interesting. They have studied characteristics and outcomes of hospitalized patients in South Africa during COVID-19 Omicron wave compared with previous wave. म्हणजे ओमायक्रॉन मध्ये जे ऍडमिट झाले त्यांचं प्रिव्हियस वेव्ह मध्ये कसं कंपॅरिझन होतं ते हॅव स्टंटेड. सो दिस इज त्यांच्याकडे दिस वॉज द फोर्थ वेव्ह, आपल्याकडे थर्ड इज. सो वेव्ह 1, वेव्ह 2, वेव्ह 3 आणि वेव्ह 4 they have treated almost 3,000, 4,000, 6,000, 2,000 पेशंट्स. त्यामध्ये ऍडमिटेड पेशंटचं प्रमाण जे होतं ते अराउंड 971 होतं त्यांनी टेस्ट केलेल्यामध्ये त्या फोर्थ वेव्ह मध्ये. सो आणि अदर याच्यामध्ये जे पर्सेंटेज होतं ते 70% होतं आणि याच्यामध्ये फक्त 40% वेर ऍडमिटेड. मीडियन एज फॉर फर्स्ट 3 years यू कॅन नोट हिअर वॉज 55 to 60. नाउ मीडियन एज फॉर दिस वेव वॉज 36. सो यंगर पेशंट are going to get infected in this fourth wave. Females are more than men, as I have told. आणि याच्यामध्ये young patients will be more affected. In fact, patient with comorbidities will be less admitted than compared to young patients. आणि acute respiratory condition ऍडमिट झाल्यावर पेशंटला O2 लागला, बायपॅप लागला, हे प्रमाण डेल्टाच्या पिरियड मध्ये इट वॉज 91%. Now in this fourth wave, in their study it was only 31%. म्हणजे त्यांना सिव्हिअर रेस्पिरेटरी कंडिशनचं प्रमाण जे होतं इट वॉज ओनली 30%. Now this is very interesting data for that. त्यांनी जे पेशंट ऍडमिट झाले 971 त्याच्यामधला व्हॅक्सिनेशन स्टेटस स्टडी केलं तर फर्स्ट 3 वेव्ह मध्ये काही व्हॅक्सिनेशनचं रजिस्टरच नव्हतं. फॉर दिस फोर्थ वेव्ह ओमायक्रॉन वेव्ह ओनली 24% ऑफ द व्हॅक्सिनेटेड पेशंट्स वेर ऍडमिटेड. इन 971 ओनली 24% वेर व्हॅक्सिनेटेड. 66% ऑफ द पेशंट्स वेर नॉन व्हॅक्सिनेटेड आणि व्हॅक्सिनेशन स्टेटस was not known in around 10%. So almost 75% of the patients were not vaccinated who got admitted in hospital. So vaccination is definitely protecting you from getting admitted. Now, जे पेशंट ऍडमिट झाले त्यांच्यामध्ये ऑक्सिजन कोणाला लागला, व्हेंटिलेशन कोणाला लागलं आणि ऍडमिशन आणि लेंथ ऑफ स्टे ते बघितलं तर इन दिस वे ऑलमोस्ट ऑक्सिजन थेरपी 80% लोकांना पहिले 3 वेव्ह मध्ये लागली. व्हेंटिलेशन ऑलमोस्ट 10 to 15% लोकांना लागलं आणि इंटेन्सिव्ह केअर मध्ये ऍडमिशन ऑलमोस्ट 30 to 40% पेशंट लोकांना लागलं. आणि डेथ्स वेर to the tune of 20 to 30%, and their average length of stay was 8 to 9 days. Now if you compare this oxygen 80% च्या compare याला मध्ये फक्त 17% लोकांना ऑक्सिजन लागलाय. मेकॅनिकल व्हेंटिलेशन जे 15% होतं only 1.6% people require mechanical ventilation and admission to ICU was only 18%. So length of stay was short, 3 days. Death percentage was 2.7%. So this is how Omicron is different from other 4 waves. So how to treat these patients? You have to take symptomatic measures. Patient allow you give any symptomatic treatment, you are best judges. You can do paracetamol, you can give antihistaminics if he has got sneezing or any other thing. No need of antibiotic, no need of Tamiflu, no need of Faviflu. You have to public health measures, you have to isolate him. Antibody cocktails should not be used. And antiviral drugs like molnupiravir, Paxlovid, Remdesivir. Swapnil is going to discuss in detail about this. These are the guidelines which is given by government of Maharashtra for treating patients. So if patient is asymptomatic or mildly symptomatic, no comorbidities, you have to just observe, no blood test, no treatment. If patient has got symptoms with fever, rhinitis, cough, if he has got even comorbidities, no comorbidities, just observe. If cough, you can give budesonide inhaler, Budecort plain inhaler twice a day देऊ शकतो. Cough, patient ला जर responsive असेल तर, and you can give symptomatic treatment like paracetamol आणि Allegra वगैरे. Symptomatic with high grade fever. In that case, म्हणजे पेशंटला जर फिवर हाय ग्रेड असेल, in that case we can use molnupiravir. Molnupiravir is very controversial molecule. Swapnil will discuss it. This molnupiravir needs to be started in 72 hours after onset of symptoms. Even if after molnupiravir fever persists, then you can admit the patient and start him on remdesivir. आणि कोमॉर्बिडिटीज जर जास्त असतील तर यू स्टार्ट विथ मोलनुपिरेव्हिर इनिशियली, आणि पेशंटला जर हायपोक्सिया असेल तर इन दॅट केस यू हॅव टू admit and start him on remdesivir. Remdesivir has got very good result in if you start early. Okay, so take home is no cause to let down our guard and relax, because the virus that transmits faster, even if milder, could lead to many more deaths, and small percentage number will be huge number. The sheer numbers could overwhelm health system, and large number of healthcare and essential staff will be off work and sick. लॉंग कोविड सिंड्रोम ही जी एंटिटी आहे ना, की ज्याच्यामध्ये पेशंटला कोविड होऊन गेल्यानंतर 2-3 महिने विकनेस, फटीग आणि रेस्पिरेटरी सिम्पटम येतात. दिस कॅन स्टील ऑकर विथ माइल्ड इन्फेक्शन. त्यामुळे लॉंग कोविड सिंड्रोम आपल्याला मिळेल, कारण इन्फेक्शन नंबर विल बी व्हेरी हाय. आणि इंडिया हॅव गॉट यंगर पॉप्युलेशन, सो दे विल बी हार्ड हिट. आणि इट विल हॅव पेशंट कसं आता एकदा इन्फेक्ट झालं की मग 7 days आयसोलेशन, सो इट इज गॉट ह्यूज सोशो इकॉनॉमिक इम्पॅक्ट. So with this, I end my presentation. Now I will ask Swapnil to take over, and after both the talks are over, we will take the question and answer session.
Yeah, thank you, sir. Is my screen visible, sir?
Swapnil, your screen is visible.
Yeah. So now we'll go ahead with the second talk, that is vaccines and drug update in COVID-19. As you all know, now there is a lot of chaos going on, whether booster to be taken, not taken, which are the vaccine to be taken. So we'll go we'll see the basics, how the vaccines are made and what are the different kind of vaccines which are to be marketed very soon. So how the vaccine works, basically, as you all know, SARS-CoV is the virus which has a spike protein, as sir is mentioned in the diagram, and which resembles, which attacks as an antigen. So you have to have some antibody in your body to prevent this attack on your body. So vaccines are there to train our immune system, which can recognize viruses or a part of viruses, so that they cannot do any inflammatory surge in our body. So whenever the vaccinated person is exposed to SARS-CoV virus, our immune system will recognize this viral antigen and spring into the action to keep us healthy. So different kind of vaccines are there. I'll show you in diagram. So which are the types, or which are the platform to develop a vaccine? So there are two categories of vaccine: a component viral vaccine and whole virus vaccines. As the name mentioned in itself, component viral vaccines means some of the component of the virus are used to develop a vaccine. And second is whole virus, means whole virus, whether it is activated, inactivated, they are used to prepare a vaccine. So we'll see in the diagram, these are the component viral vaccines, means in some vaccine only the protein part of the virus is used. In some vaccines, virus like particle which are mimic the structure of the virus, but there is no genetic material. Some viruses, some vaccines which are DNA, RNA based vaccines, which carries the viral genetic material, which provide instructions for making viral proteins, and antibody will act against it. Other vaccines like non-replicating viral vector. Non-replicating means they contain the viral genetic material, but they cannot copy once they transmit it in our body. A replicating viral vector means vaccine contains the viral genetic material, but they are harmless and they can copy itself. And whole virus vaccines means they are live attenuated vaccines. These are the killed vaccines, means the virus is dead but inactivated and killed, and they are transferred to produce the antibodies. So this is the basic structure where all the vaccines will derive their marketing and this thing depending upon this. So in looking to the current scenario, as we have taken 2 doses of vaccine, how the Omicron is different, because Omicron can give a phenomenon kind vaccine escape. Means whatever the immunity you have gained with the vaccine, that may vanish off and virus can make entry like Omicron strain, or better definition to this VOC, variation of concern. So this can escape your whatever the immune system you have gained, and they can enter in your body. So the government has come up with a booster phenomenon. Now the confusion remains which booster to be taken, whether to continue with the same which has taken previously or to take a different. So there are papers which have suggested that, see, if you take a two different vaccine first, they have, for which prepared they are of vaccine component se prepare kiya gaya hai, and second vaccine, if you take a pure whole vaccine, then your body will get a better immunity. But if you get a better immunity, there are certain side effects that you may have certain side effects if you take a two different vaccine. So as we'll go, one paper which is published, mix and match vaccination. Mix and match means two doses has been taken from the same vaccine and booster is taken from a different heterologous vaccine. They have shown that among the heterologous booster combination, boosting with mRNA vaccine after a vector primary series is more immunogenic. They give a better immunity. So mix match vaccines, they are better in terms of immune response than a homologous booster, and they should be given within 6 months. But heterologous booster of viral vector vaccine they can give rise to more adverse effect. It depends upon local or systemic reactogenicity by ourselves to that vaccine. So administration of the booster doses, whether homologous or heterologous, need to be taken into account. As you know, there is a waning response after a certain period of time of doses. So recent publications, which is just published in 11th of January, so benefit of booster dose incidence in COVID young health workers. As you know, Omicron is affecting the young adults, and looking to the current scenario, it's more affecting to the frontline workers rather than the publicity. So our frontline workers coming in groups, they're coming positive. So whether we should go ahead with the booster for them or not. So this is published in JAMA, where 650 participants were there. Average age was 41 years, who received a booster. And they have noticed that among the cases who have received the booster, there is a relative reduction of COVID-19 infectivity into the disease by 93%. So administration of the booster dose which reduces your viral burden load in your body significantly by 93%. This is about all the young adults. What is the data published of effectiveness of the vaccine against the critical COVID in adolescent? As you also see, if you take a vaccine doses, mRNA vaccines in adolescent group, the chances of getting ICU admission and hospitalization is prevented. So the booster doses among the young adults is also to be promoted. As I have shown in the figure, there is an immune escape phenomenon, but those patients, a recent study which is published, those patients who have got vaccinated along with the booster, they partly they show immune escape phenomenon, but major of them gives a protective immunity again, whatever the variant these are. In this study, they have included the Omicron variant also, so which give a better protective immunity if you have taken a booster dose with a homologous. So what does Government of India says? Government of India has little bit different point of view in terms of they don't want to reduce they don't want more mortality, and they don't want more admissions. So government want to reduce the mortality and admissions at a population level at the least cost and least side effects. If you take a heterologous vaccine, there will be more immunogenicity, but there may be little bit percentage-wise higher chance of getting vaccine-related side effect. And once the myth has been spread, vaccine-related side effects are more, no people will go towards the booster effect or booster doses, and the measure of the population will be vulnerable to a disease rather than to limit it to the infection. So the best option what they chose is give a homologous booster to most vulnerable population, because heterologous boosting has higher advantage of higher antibodies, but also have higher chances of side effects. So they have put a term like a clause of medical advice. So though a nutshell, vaccine should be taken to high risk population, put a homologous booster to prevent lesser side effects. As WHO said, boosters are unnecessary, but previous two papers they have shown booster have reduced 93% of the hospital admission burden. So we should take it on like the same dose which has taken previously. And as WHO, they do not want to contradict with the WHO, so we don't mention it as a booster dose. We mention it as a precautionary dose to prevent a further complication or infection. So, what is the final note on the vaccine? As you know, since last 2 years, our normal life has disturbed, and new variants are coming, and we are not finding any final pathway how we should go ahead. So ultimately, vaccine is the only light at the end of the tunnel. So if you vaccinate yourself better, your immunity booster will be high. Even if you come across with the different variations or variants of the COVID, your vaccine immunity will give you a protection, which will not end up in the hospitalization. So vaccine hesitancy and inequality of the availability or mutated strains, these all have disturbed our normal life. So to boost it or to combat it, we have to vaccinate ourselves. We have to take the benefit of the booster dose in reducing the rate of infection. As we have shown, the reduction is around 93%. So it is important to vaccinate the whole world, including children, to achieve a herd immunity so that disease becomes endemic. As the recent literatures are coming on a pediatric population also, one paper which I have shown, which is a very good effect on adolescent population. So what are the available vaccines in India? So far, India has approved 6 other vaccines. Currently using only 3: Covishield, Covaxin, and Russian-made Sputnik. These are among these, Covishield and Sputnik is the vector-based, and Covaxin is killed attenuated, whole vaccine killed attenuated. Recently, yet to be marketed, India has also approved Zyco VD vaccine, which is first Indian-made DNA vaccine. As you have seen that it's a needle-free vaccine jab, yet to be marketed very soon. And other vaccines like Johnson & Johnson single-dose vaccines and Moderna, which is available in US, recently CIPLA got a permission to import it and market it. So it will be same like a Moderna vaccine. So, but we don't know exact date when it will be available in India. So before that, the homologous vaccination has to be given a preference and to be taken earliest. Which are the new upcoming vaccines like Corbevax? Corbevax is a recombinant protein subunit vaccine, which is more than 90% effective in latest US-based clinical trial. Other vaccines are HGC-019, which is the first mRNA vaccine produced by a Pune-based company in collaboration with the Seattle HDT Biotech Corporation. And very soon, a nasal vaccine by Bharat Biotech and oral vaccine by Gufic Lab Sciences will be coming soon by the recently in coming 6 months of the 2022. Now, second topic is drugs. This is most interesting topic today, I suppose. So, what works is not available, like Sartovimab or Phenoxide, and what do works is readily available. But we are confused whether to be used, whether not to be used. Even if you prescribe Molnupiravir, the second day patient calls you, sir, ये तो ban हो गया है, अब ये return दे दूं क्या, return लेगा क्या? So unnecessary contradictions are happening around us because of the confusion. Once the people is confused, even if you convince them that this is best drug which will prevent you from hospitalization, people won't agree. Rather than they will force you not to write it, and you have to force them whatever the means way. Even if you give literature, it is the only the published or whatever the mentality of there, they will accept only that. So we have to take a confidence, like government also to be in confidence and patient also to be in confidence while using the drugs. But this slide is very important. What does not work is very important rather than what works. So unnecessary or pill burden should not be high. What you have mentioned, what we see which don't work at all is Flavipiravir, azithromycin, doxycycline, or other any antibiotic which do not work. It's a viral infection. Antibiotic have no role unless the patient develops a later on secondary bacterial infection. Ivermectin and hydroxychloroquine is completely out in the second wave only. Convalescent plasma is out. Any kind of vitamin A to Z is out. Colchicine, other immunobiologicals like itolizumab, bevacizumab don't work in this scenario, and coronil on other herbal medications like Carda and all. So what works is observe, wait and watch, and monitor your symptoms. Now we'll go ahead with the one by one drugs. Which drugs are better? A few words like we'll like to highlight on Molnupiravir. So molnupiravir is basically antiviral drug which has been published by NEGM in a non-hospitalized patients. This article is published, I think, around December 2021. So what they have shown, the side effects. I want to mention about the side effects because side effects on the use of molnupiravir in non-hospitalized patients were very less. The mainly diarrhea, dizziness, and bacterial pneumonia. So in this trial, they have shown that molnupiravir was highly effective in the treatment of COVID-19 without evidence of safety concerns. But the crux is when initiated within the 5 days of onset of signs and symptoms in a population who are non-hospitalized, who are unvaccinated, and who are at risk of progression of severe disease. So this is real the indication. Basically, those patients who are non-vaccinated, those patients who are non-hospitalized, and who are at risk of progression to severe disease, molnupiravir found to be a very effective regimen. Now, the people who are young, whether to use it, not use it, will go ahead and we'll see. FDA has given approval in almost December 23, like additional drug, which has been very useful in treatment of COVID-19 pneumonia in certain adults. Again, I want to mention you is authorization provides additional treatment option against the COVID-19 virus that can be taken orally because there is no other drug available. And those patients who are mild symptomatic, you cannot ask them to admit. You cannot force them for antibody cocktail because whatever the antibody cocktail available in India, that as far as so far it doesn't work. And the antibody cocktail which works is not available in India so far. So we have to have thorough knowledge of ourselves whether in which patient it should be used and in which patient it should not be used. Now, molnupiravir, where it should not be used, that is a very important slide. First, pregnancy and lactating mothers and childbearing mothers, we should not use. Second, the contraindications is patients who are less than 18 years of age because it can harm the cartilage and bone formation. Second, those third criteria where it should not be used is those patients who are hospitalized. There, we should not use molnupiravir. Fourth, one person from the family is positive, other person as an exposure or post-exposure prophylaxis, he should take molnupiravir, strictly no. So these four are strictly no. One, those patients less than 18 years of age, child year or pregnancy status, those patients who are requiring hospitalization, and fourth, exposure prophylaxis. Other indications like where we should not use, it is not used to use more than 5 days, and those patients who have renal impairment and hepatic impairment. As you know, a few days back, the government itself published the literature like molnupiravir benefits outweighs the risk. So where we should use it, where we should place molnupiravir in today's scenario is those patients who are at high risk of progression to the disease or who will require admission in the coming future, those with obesity or multiple comorbidities, age more than 60, definitely we should promote them to use a molnupiravir molecule to have laser admissions. As you all know, sir has mentioned that there is no role of antibody cocktail. So different antibody which work in Omicron variant is sotrovimab. This sotrovimab, the NEGM article published in November 18 is as they have done a phase 3 trial where 500 milligram dose of sotrovimab was used in 292 patients. And those patients who have got this antibody cocktail, they have reduced the risk of disease progression. So this is very wonderful drug, but yet to be available in India, and cost is around 1,62,000. So those patients who are highly affordable, once it is available, we can definitely promote them to use it to have lesser disease complications. Other drug which will be upcoming in the coming months, it will be coming to market is Phenoxide. So what is Phenoxide? Again, it is a similar molecule like molnupiravir. This has shown a better effect or lesser the degree of progression in COVID-19 pneumonia. It can be used in high-risk adult as well as high-risk pediatric patients of 12 years and more age and weighing at least 40 kg. So it has a certain combination with the HIV medicine so-called ritonavir. As you all know, so ritonavir induces a CYP450 enzyme, so it should be cautiously used in liver disease patients. Patient may have side effects with the drug. So what it does do? It reduces the risk of hospitalization or death by 89%. And if used within the 3 days of symptom, and 88% if used 5 days of the symptom onset. Very soon, Pfizer, Sun Pharma, Dr. Reddy's, and Optimus Pharma in India will market this drug in the coming months. So, what use? If the patient is not fit for molnupiravir use, the patient is running fever, and whether to admit, whether not to admit. So, a different study which has been conducted in recent VOC, that is variants of concern, where if the patient is running fever, and in that case, rather than giving the 6 doses of remdesivir, 3 doses of remdesivir proven to be effective by IV course rather than a 6 dose of remdesivir in current scenario. So, as sir has shown in dictated very nicely in a graph, I have written it the PPT format. Those patients who are asymptomatic, you have to write down on your OPD paper whether the patient has taken vaccines. If yes, watch for their symptoms. If the patient is fully vaccinated but high running fever spikes, definitely you can counsel them to take a molnupiravir. The only problem with molnupiravir is nausea. Fully vaccinated people, but no booster dose taken, and recent Omicron is there, with comorbidities are there, definitely you can go ahead with the molnupiravir. As Phenoxide is not available so far, Sortavimab is not available. Depending upon the affordability, molnupiravir is highly cost-wise also safer. Those patients who are not willing to take molnupiravir with comorbidities, you can at least counsel them to take 3 doses of remdesivir to prevent the disease progression. Unvaccinated population with running fever spikes, definitely you should go with IV remdesivir. So as sir has mentioned, there is no genomic testing should be done, but looking to the current scenario, looking to the current infection, there is only Omicron variant is available, and it is affecting only upper respiratory tract way. So with comorbidities, molnupiravir, if the fever is persistent, promote them for remdesivir. This is the only the nutshell of the treatment as far so far. There is no retesting advice after the home isolation period is over. And sir has mentioned that asymptomatic contact should not be tested for COVID. They should be promoted for the home quarantine. So this is the cardinal scale, what we follow once the patient is hospitalized. If the cardinal scale is more than 4 or 5, the available medications are the steroid, Clexane, remdesivir, and baricitinib tablet in patients who are requiring high O2 therapy. So current admissions, basically why we should keep in mind, as you all know, those patients, those population who is healthy, they will not require hospitalizations. Current hospital admissions are patient admitted with a stroke and do a COVID test and it comes positive. So it requires a total different, it adds up the mental burden. The kind of care which we give in non-COVID ICU is totally different than the same kind of treatment which is required for a parent disease in COVID scenario is totally different. Many of the time in non-COVID ICUs, we allow patient to meet, we allow patient to stay there for 1 or 2 hours. And the same scenario, if it only the tag of COVID-19 comes positive, in certain in the same period or same scenario, we don't allow them to stay there for more period of time. So this is kind of mental stress we are adding. So what important in COVID-19, current COVID-19 scenario is those population with higher comorbidities, they should be take more precautions. They should be promoted for booster. And the take-home message, despite being more contagious, replication of Omicron variant in human lungs is much less than the Delta variant as sir has shown. Severity of the disease is expected to be less than the Delta variant. Severity is not always depend upon the viral strain. It also depends upon the host immune response. So a vaccination is promoted, and we should promote them in a frontline workers. People who are not vaccinated or not previously infected, and people with comorbidities, infection can cause severe disease. Thank you.
थँक्यू स्वप्नील.
सर क्वेश्चन्स आहेत बघा चॅट मध्ये आलेले.
हो, मी आता एक एक करतो आणि नंतर सुद्धा कोणाला बोलायचं असेल तर आपण याच्यावर पण क्वेश्चन आन्सर घेऊ. स्वप्नील, चॅट मध्ये 3-4 क्वेश्चन आलेत. वन वॉज रोल ऑफ अँटीबायोटिक्स. सो डॉक्टर स्वप्नील has answered it. Antibiotic has got no role. Doxy, amoxy काहीच नाही unless you have got a secondary infection. ओके. स्वप्नील, तुला अजून काय अँटीबायोटिक्स बद्दल सांगायचं?
No, sir. There is previously used a doxycycline as a preventive measure, but as in the current scenario, no antibiotic has been used in the COVID-19 once there COVID-19, unless patient has certain other infections along with the COVID. Those patients who have UTI, those patients who have other infections, they have to be watched and they should be proved to give antibiotics.
And then role of steroids बद्दल असं आहे, जसं स्वप्नील has rightly said, if you see figure ही स्वप्नीलने दाखवली होती, याच्यामध्ये those patients and those who are need ऑक्सिजनची रिक्वायरमेंट सुरू झाल्यावर there is a real role of steroids will start. स्वप्नील, you have to add anything? ती स्लाइड दाखवू नये का?
दाखवतो.
हा, हीच. Patient who is requiring supplemental oxygen, in that case you have to use steroids. OPD basis वर आता सध्याच्या याच्यामध्ये स्टेरॉइडचा काही रोल नाहीये. ओके.
आणि सर नेबुलाइज आपल्याला असं आपण सजेस्ट करू शकतो का?
नेबुलायझेशनने इट प्रमोट्स, म्हणजे त्याच्याने हे वाढतं, स्प्रेड वाढेल, त्यामुळे नेबुलायझेशन इट्स ऑलवेज डिस्करेज. त्याच्याऐवजी जसं मी म्हटलं इनहेलर आपण वापरू शकतो. नाही, मग ते इनहेलर त्याला शिकवायचं आणि इनहेलर घ्यायचं, नेबुलायझेशन नाही. ठीक आहे, कारण घरी म्हटलं तरी तो बाकीच्यांना रिस्क करेल ना घरातल्या. अजून एक क्वेश्चन आलाय स्वप्नील, 7 days आयसोलेशन पिरियड किती पाहिजे? ऍज वी हॅव डिस्कस की आयडियल पिरियड वुड इज फॉर, म्हणजे जे होम क्वारंटाईन असतील त्यांना 7 days आहे, आणि आपण घरी गेल्यावर पण सांगतो. आता जे पेशंट हॅज गॉट सिव्हिअर डिसीज ऑफ आहे, की ज्यांना खूप सिव्हिअर डिसीज आहे, अशा केसमध्ये आपण ते मोस्टली दे आर ऍडमिटेड, त्यामुळे त्या केस तो पिरियड पण होऊन जातो, आणि त्या पिरियडमध्ये आय थिंक आफ्टर डिस्चार्ज ऑल्सो इट शुड बी 7 days, दोज हू आर हॉस्पिटलाइज्ड फॉर सिव्हिअर इलनेस. स्वप्नील, युअर कॉमेंट.
Hello.
Yes, sir.
Hello. One more question I would like to ask. Suppose if the
Let him,
patient
एक मिनिट सर, फक्त सरांना हा संपू द्या, मग तुम्ही विचारा.
Okay.
आयसोलेशनचं. येस सर.
Many of the time what happens, patient fever 2-3 दिवस होऊन जातो, आणि मग we ask them to go for testing, and test result come 24 hours. Till the time the result comes, already 4 days are over. But as we know, government has all data, and they have clearly mentioned, once from the day of your result is positive, from day onwards 7 days isolation is mandatory to prevent, because you don't know which family member who are at risk who will require hospitalization. So ideally 7 days protocol after your result is positive, we should follow 7 days isolation period, irrespective of your symptoms.
Hello.
हा, बोला, विचारा सर.
Suppose the patient has been vaccinated 2 doses. He is suffering from Omicron disease. He's after 1 week, when he should go for a booster dose?
Sir, ideally 6 months.
6 months. Oh.
6 months.
Acha.
ते तर म्हणतात 6 months घ्या बूस्टर.
Okay. And if he is suffering from just a severe fever, cold, and the test is negative?
Sir,
Symptoms
you
are
considered it, see, so kind of viral fever you are dealing with.
Yeah.
So in that case, if it is not a COVID proven, the guideline recent literature says you can take it at earliest as after the 3 months of your recent viral infection. 3 months.
Okay. Thank you.
Okay. And a question about anti-flu, oseltamivir. As you all know, it's an anti-influenza drug. Recent now, out of 100 people, 99 are coming with Omicron positive or COVID positive. So in the current scenario, there is no role of oseltamivir, only if he is positive of viral infections and you have proven it of H1N1 positive. I suppose there is no role of oseltamivir also, because newer antivirals are available. So we should promote them to have, they have better coverage of variants of concern.
सर, एक बूस्टर डोस बद्दल क्वेश्चन आहे बघा.
काय रे? ते आता सरांनी सांगितलं ना की जनरली इंडियामध्ये तर सेमच बूस्टर घ्यायचा आहे जो आपल्याला घेतलाय तो. क्रॉस बूस्टर बद्दल इंडिया इज नॉट टू कोविन वर वगैरे आपण आता ते तुला दिवस देणार नाही क्रॉस बूस्टर, त्यामुळे आपल्याला चॉईस नाही तो. म्हणजे क्रॉस वॅक्सिनेशन जे आहे त्याचे स्टडीज आर बेटर बट दे आर डेफिनेटली नॉट प्रूव्हन. आणि मग त्याच्यामुळे ते एक आहे. त्यामुळे फ्लुवेरीचं काय हे नाही. सीआरपी बद्दल एकाचं आलंय मेसेज, सीआरपी एस्टिमेशन. सो सीआरपी इज डेफिनेटली इनिशियल स्टेज मध्ये जसं म्हटलं इनिशियली की इन्व्हेस्टिगेशन सीआरपी इज नॉट रिक्वायर्ड इफ पेशंट इज माइल्डली सिम्टमॅटिक. पेशंटला सिव्हिअर सिम्टम्स असतील, त्याचं सॅच्युरेशन हे होत असेल, इन दॅट केस डेफिनेटली सीआरपी विल हेल्प. सीआरपी विल टेल अबाउट सीआरपी. एक लक्षात घ्या, कुठल्याही फिवर मध्ये तुम्ही डेंग्यू, सिव्हिअर डेंग्यू मध्ये सीआरपी केलं तरी 150-200 येईल. सीआरपी मार्कर ऑफ इन्फ्लेमेशन, सी रिएक्टिव्ह प्रोटीन. त्यामुळे कुठल्याही बॉडीमध्ये इन्फ्लेमेशनरी रिस्पॉन्स जास्त असेल त्यावेळेस सीआरपी लेवल बी हाय. सो वन्स यू फील दॅट पेशंट इज मॉडरेटली सिम्टमॅटिक, इन दॅट केस सीआरपी इज युजफुल आणि सीआरपी विल टेल अस अबाउट द इन्फ्लेमेटरी ऍक्टिव्हिटी इन द बॉडी.
तर एखाद्या पेशंटचं सीआरपी जर जास्त असेल तर आपण त्याची आरटीपीसीआर केलीच पाहिजे का?
त्याला रेस्पिरेटरी सिम्पटम असतील तरच आरटीपीसीआर करण्यात येते. त्याला कफ फिवर नसेल आणि सीआरपी कशाने झालं तर.
ओके.
आता देर आर 2 क्वेश्चन्स. इज आयसोलेशन 7 days नंतर पेशंट कॅन मिक्स इन द फॅमिली. देर इज नो क्वेश्चन बट ही शुड बी विथ मास्क ऑन. स्वप्नील, एनएलआर रेशो. हा बोल, प्रेग्नेंट लेडीचा प्रश्न घ्या.
So what to prescribe in a lactating lady? Just observation, sir. If fever is persistent, definitely we can promote them for remdesivir, because we have found out that remdesivir, though if we give, it is safer. It has so far not caused any side effects. But I don't think so in current scenario. Though pregnancy is there, but disease is progressing towards the moderate to severe. So pregnant lady, no oxygen requirement, wait and watch. Oxygen requirement, promote them for remdesivir.
In our setup, we have used for remdesivir in pregnant patients for few patients, and safely they have delivered. You may observe that they have safely delivered over the period. Because if the O2 requirement is increasing, in that case there is no point in holding on remdesivir, because it is mother should be our first priority, then baby. But even remdesivir has got no proven side effect for baby as such, as is the case with molnupiravir.
सर एनएलआर रेशिओ बद्दल तुम्ही काहीतरी बोलत होते.
स्वप्नील, एनएलआर रेशो न्यूट्रोफिल टू लिम्फोसाइट जो आधीच्या याच्यात पण होता.
If previously it is to be correlated as lymphopenia is a severe viral marker, and if your lymphocyte count is increasing, that denotes that your viral or stage of viremia is reducing. In the looking to the current scenario, we don't count NLR ratio because though lymphopenia is there, clinical condition of the patient matters a lot as compared to the CBC. So if your strains is different and it is causing more lung damage and requiring oxygen, then our eye goes on how much are the lymphocytes. So recovering lymphocytes is the indirect sign of recovering viral infection. So there is a less requirement of steroid. That's what the practical point will take on NLR ratio.
There is a question about efficacy of Covaxin. Covaxin efficacy around 70 to 75% hai.
Thank you, sir.
Okay, thank you. So happy Sankranti to all.
Thank you.
We hope that you enjoyed the session, and you will definitely help you in managing patients in coming few weeks. Thank you.
Thank you.
Thank you, sir, once again.
Yeah.
Thank you, sir.
Thank you, sir.